Hello, yes, and thank you. Thank you for the second opportunity to present in this conference. And the focus of my talk in this short time frame will really be to give the whistle-stop tour of how to use multi-omic biomarker analysis to learn about how to interpret a trial, with a real focus on minimally invasive biomarkers, particularly in the blood. So I'm going to use as an example the Prince Pancreatic clinical trial that was recently presented at ASCO, in which Bob Bonderheide at UPenn has some beautiful work that he's published looking at CD40 in combination with chemotherapy and checkpoint inhibitors, specifically PD-1. And so the Parker Institute with the Cancer Research Institute set up this study, Prince, with our 7 centers to enroll a study, a randomized phase 2 study that had 3 arms. So it had PD-1 plus chemotherapy, gemabraxane, frontline pancreatic cancer, CD40, gemabraxane, chemotherapy, and then the 2 immunotherapies in combination with chemotherapy based on the preclinical work. And really, from the study that we presented at ASCO, what we found is that the 2 combinations, the PD-1 plus CD40 and chemotherapy, did not give activity. And what we did see, surprisingly, was a p-value with PD-1 plus chemotherapy. And we also saw a numerical improvement with CD40 plus chemotherapy with a p-value of 0.06. So what we really wanted to do was use the multi-omic, multi-parameter analysis of tumor, blood, and stool using a number of orthogonal assays to ask, did we have, what's the relative contribution of the various immunotherapies? Do we have a biased patient population in any way, like MSI high for PD-1? And then can we show that there are different in who is responding to PD-1 or CD40 with chemotherapy. And so I'll show you some of the data that's been presented, but first to really think about, as we look at these minimally invasive biomarkers or tumor-based biomarkers, is the broad profiling. So in order to really understand and learn in a science-driven way, we'd have to have both hypotheses going in and directed panels. But given the complexities and the broad number of cell types involved in the immune system, we really need to devise panels that can allow us to have broad immune profiling to get a look-see at the T cells, the B cells, and the other cells that are really critical to bolster anti-tumor immunity. So we have used a panel that was really put together by many of our Pisces collaborators at UCSF and at Stanford, Sean Bendel and Mike Spitzer, and use this across all of our studies to really try to learn about the different immune features that are at baseline and on treatment in response to different drugs. And then we have a deep dive, because really what we're not just trying to look at immune presence and activation or who's there, but really the phenotype. And one thing that we've learned from many of the people within the Pisces network in the immune field is that the quality of the T cells matter. And so we have put together, in collaboration with John Weary, really a broad T cell panel to look at T cell fitness for both exhaustion or the ability to have stem-like qualities. And then Louis Lanier collaborated with us to come up with an NK panel that I will not present data on today. Critical to all of these multi-omic, multi-parameter analysis is the ability to really do the computation. So having access to bioinformatics capabilities that can integrate both the biomarker data and the clinical data, because looking at the correlation of these molecular and cellular features with clinical outcomes and features is really how we're going to learn best about the patient. And it's the totality of the data that will really inform us of how to move forward. So quickly, I'm going to focus on the blood just to show how this can be useful in a clinical setting. In that, one of the first questions we asked was, okay, we have chemotherapy, standard of care, so we have an active component to our treatment. Do we really see effects of PD-1 treatment and CD40 treatment in the different arms, and focusing on Arm A, which is PD-1 treatment, and Arm B, which is CD40 treatment alone. I won't talk about Arm C in this presentation to go quickly today. But indeed, we do see what we expect with a PD-1 treatment is this activation, proliferation of effector memory T cells, which has been seen broadly in PD-1 clinical studies in blood in the PBMCs. Likewise, in the blood, we do see effects of the CD40 that are unique to the CD40 containing arms, in that we see activation of the dendritic cells, which is not seen in the PD-1 treatment arm. So did the drugs hit their target and tickle their targets? In fact, they did, and we do see immune activation that is distinct with PD-1 and with CD40. Now, can we see any association of immune characteristics with outcome? And so again, focusing on the blood-based biomarkers, taking these deep immune profiling panels that we have, both the CyTOF and the T-cell X50 panel, what we found very interestingly was that there were higher baseline levels of CXCR5 positive effector memory CD4 cells with improved outcome to A. So in the Kaplan-Meier curve here, higher levels worked well for A, but we see quite the opposite with CD40. So what the one characteristic that works for PD-1 treatment does not seem to have a high level correlating with effects for CD40. It's the exact opposite. So very interesting from a mechanistic standpoint, thinking that these two immunotherapies really have very different mechanisms of action. Likewise, when we look deeper at what higher level of cells portend a bad outcome with CD40, what we see are these exhausted T cells really correlate with bad outcome uniquely to the CD40 chemotherapy arm as compared to the other arms. And this mechanistically could make sense, because if you're terminally exhausted or exhausted T cell, no matter how much CD40 antigen prime you give, you're not going to be able to invoke an immune attack on the tumors. In addition to immune profiling of PBMCs, we also did a number of assays looking at proteomics using the Olink platform, as well as a mass spec-based approach. And what we found is things that we would expect, that immunosuppressive cytokines, really higher levels across the board, look like worse outcomes for the patients, but maybe with more of an influence on the CD40 arm than the other arms. And uniquely, IL-10, which has been published to be correlated with the B cells in particular, seems to be unique to CD40. And across these Kaplan-Meier curves, we can see some differences between the three arms, even in a proteomic approach from blood. And lastly, to just touch on another biomarker that I think has a lot of utility is the circulating tumor KRAS assay. And what this is showing is the red is showing tumor shrinkage, the blue is showing changes in circulating tumor KRAS levels. And across this hodgepodge of graphs just shows that we were able to detect it in some of the patients And we did see decreases in response to the treatment. Very interestingly, as we've dived into the specific allelic variants of KRAS, we have found differences and good concordance. First off, good concordance between tumor and blood in terms of the KRAS allelic variants that are detected. But we have seen differences in the response to CD40 versus PD-1 treatment with what KRAS mutation would correlate, associate with better outcomes to the different treatments. And we're looking at how those features of these oncogenic mutations might influence the immune state within that patient. So all of this biomarker work is wonderful, generating large quantities of data, but integrating the data to really get an understanding of the rich interplay between the tumor and immune cell is of critical importance. So I can't understate both the bioinformatics, but also to have that depth of immunology. So when you see a CD244, 2B4 is the more common name, marker come up on a T cell, that you can think about the biology. When you see the CXCR5, CD4 T cells come up, that you know questions to really look into the literature and think about the biology. So I think cross-functional teams with multidisciplines are as important as multi-omic, multi-parameter analysis to be able to learn from the data that's generated. So with that whistle-stop tour, you can see hopefully that blood-based biomarkers can teach you a lot from how to interpret a clinical trial and thinking about both, did the drugs work, but also can you select patients to enrich for better outcomes in response to treatment. So thank you.